Buti na natsempohan din namin na may time ka ngayon.
Oo, sir, nakabakasyon po ako.
Saan ka sa Australia? Sydney?
Canberra po.
Ay, Canberra. Baba yun, ano?
Yes, sir, capital po.
Oo. Malamig ngayon dyan.
Oo, sir, sobrang. Pero hindi na ako nilalamig, ninenervyos kasi ako.
Ikaw pa ba? Diyos ko, sanay ka na sa ganito.
Eh, sir, saglit lang po Hindi ko naman na makita.
Ayan, so as of now, we have, I think, 6 participants. Pero we are expecting 20, 30 participants.
Nahiya na ako.
Mahiya.
If I cannot find it. Saglit lang, sir.
Sige lang. Tignan mo dyan sa mga tabs, yung share screen. Sabi
Dropbox, Google Drive, Dropbox.
New share.
I need the one in my PowerPoint. It's in the desktop. It's not here.
Hello po.
Hello, good afternoon. Sino yan? Si Kathleen.
Good afternoon din po, sir.
Oh, it's nothing naman. Click here to launch the meeting. Open the meeting. Oh my God, where is it? Sir, give me 5 minutes Hanapin ko lang.
Sige. Take your time.
Share meeting. Okay. No, I should put it in Dropbox or Google Drive. Store it in this. The choices are here. Yes, I have to share it from or this one. Can I have to? Can you share? This one. Can you put it in Google Drive? Copy. No, sorry. This one again. Okay, wait.
Why did you share the screen there?
I should share it from here. Screen share video.
In this video, you
Advanced. Okay. Motion of scan.
And put your thing inside there. Put your PowerPoint inside there.
Yeah. How? Here.
So minimize it.
My PowerPoint is. Like that. Okay. Then F5. I cannot see it. It's not. Okay. Hello, sir.
Hello, hello. Ano, okay na tayo?
Okay, sir. Ready
Ready
na
ka
po.
na? Ayan. Okay, so
Saglit. Check ko lang yung slide ko, sir, kung ito yung my video.
mm-mm.
Okay. Sige, sir. Ready na po.
All right. Ayan, so good afternoon. Good afternoon to all our students. May mga ano tayo dito, may mga incoming first years. We have second year, third year, fourth year, and graduating students. Magandang tanghali sa inyong lahat. And would like to, at this early, would like to thank our resource speaker, Dr. Floricar Santos. Finally, ay napagbigyan na niya tayo sa sobrang hectic ng kanyang schedule way back nung nandito siya sa Philippines. But now, she's on a vacation, na stranded sa Australia, kaya maluwang ang kanyang schedule para sa atin. And to formally start with our webinar lecture, this is actually our second webinar lecture for the month of June. And we are expecting more resource speakers to be joining us for this educational opportunity. So, ladies and gentlemen, I would like to introduce to you our resource speaker for this afternoon. She graduated. She had her elementary education at Kasibu Central School, and she finished her high school at Kongkong Valley National High School. Naging estudyante po natin siya sa PLT sa College of Nursing, I think 2012, if I'm not mistaken. Ayan. And she's a registered nurse. She passed the licensure examination for nurses, and after which she enrolled in the College of Medicine at the Our Lady of Fatima University in Valenzuela. And currently, for the information of everyone, she is having her postgraduate internship at the Our Lady of Fatima Medical Center in Valenzuela. So without much ado, I would like to introduce to you ang aking kababayan mula sa Cebu, Dr. Floricar Santos, RN.
Okay. Thank you, Sir Prince. Good afternoon, Sir Prince. Good afternoon, everyone. Hello, colleagues. I am Floricar Santos, and I'm going to talk about appendicitis. So, vermiform appendix was coined from the Latin word appendere, which means hang upon, and vermiform, which means worm. You will understand in the next figure why it is called vermiform appendix. You can see in this picture that the appendix is hanging at the tip of the cecum, and it has a vermiform or worm-like appearance. So its worm-like appearance is achieved during the 5th month of the development of the embryo. An appendix is a closed-ended narrow tube that has an average length of 6 to 9 centimeters. It may vary, can be less than 1 centimeter from 6 to 9 centimeter or more than 30 centimeters with an outer diameter of 3 to 8 millimeters and an inner diameter of 1 to 3 millimeters. About its orientation or its position, it can be retrocecal, which accounts for 64%. Retro means behind the cecum, or in the pelvic, which accounts for 32%. Post-ileal, 0.5%, pre-ileal, 1%, and subcecal for 2%. Now, where is your appendix located? It is very easy to say at McBurney's point, at right lower quadrant of your abdomen. But in the OR, the surgeon will ask you, what is McBurney's point? So what is McBurney's point? It is a point over the right side of the abdomen, which is 1/3 from the anterior superior iliac spine, from the distance from axis to umbilicus. So this is your axis or anterior superior iliac spine, and this is your umbilicus. You're going to draw an imaginary line and cut it into 3. 1/3 from the distance from axis to umbilicus, that's where you can find your McBurney's point. Blood supply. This is my favorite part of the appendix. So this is your abdominal aorta. It has 3 unpaired branches. Above here is the celiac trunk and superior mesenteric artery, then inferior mesenteric artery. We will focus to superior mesenteric artery, which will give branches, but we will just focus to ileocholic artery that will then branch and give appendicular or appendiceal artery, which is the main blood supply of appendix. Just memorize this: AA, SMA, ICA, then APA. So for many years, appendix was an erroneous organ, and it is believed to be a vestigial organ and it has no function. Also, in the theory of evolution of Charles Darwin, it's just a remnant of the cecum or the large intestine for the humans and the primates. But now it is well recognized that appendix is a part of or an immunologic organ that secretes immunoglobulin, particularly IgA, and it is also recognized as a reservoir of healthy bacteria. Now we're going to tackle about appendicitis, which is the inflammation of the appendix. During 1500, it is known as peritiphylitis or the inflammation of the cecum. It is the most common acute surgical disease of the abdomen, and it is known as the bread and butter of surgeons because it's very common. Like when you are in ER in one night, maybe the least appendectomy that you will have in one night or 24 hours, 5 people. That's the least na yun, pinakamababa na yun. It peaks in puberty and early adulthood, and in incidence rate, there's a higher preponderance in male with a 1.3:1 ratio. So in pathogenesis, obstruction is the dominant causal factor. Fecal leak is the most usual cause of obstruction, which is a hard stony mass of feces in the intestine that cannot be passed. So it's also known as coprolith or stercolith. Also, another reason of obstruction is hypertrophy of the lymphoid tissue, because as we have said a while ago, appendix is a lymphoid organ. Inspissated barium. Barium sulfate that is used in barium enema as a barium contrast, is an insoluble salt. That's why it is believed that it can obstruct the abdomen or the appendix. Vegetable and fruit seeds, yung seeds daw ng guava, ng tomato, pero fecalit pa rin ang most usual cause, okay? Intestinal worms, Ascaris lumbricoides, and Enterobium vermicularis. Those are the pinworms that you can see in the intestine. Also, so with the first stage, congestion is the first stage of appendicitis, wherein there is a luminal obstruction. And in this stage, it starts with proximal occlusion. Proximal occlusion, the base part of the appendix is occluded. So there will be a closed loop obstruction kasi it's like a tube. Sarado siya sa isang side. So there will be a closed loop obstruction. And then there will be a rapid distension due to the continuous secretion of mucosa and the rapid multiplication of normal flora. It comes to a time that the venous pressure is exceeded. What do I mean when there is a venous pressure that is exceeded? The capillary and venules are occluded. So hindi makakabalik yung dugo na nakasupply doon sa appendix while arterial inflow continues. So tuloy-tuloy lang ang blood supply, pero yung balik ng dugo impeded kasi nga occluded na. May obstruction. So that is the first stage, congestion. The second stage is suppurative. Suppurative just means there's presence of pus. Why? Because there's infiltration of PMN or polymorphonuclear cells, also known as white blood cells or neutrophils. So that is the second stage. Cannot find a picture, but then suppurative appendicitis is just confirmed after appendectomy. Tapos pag open ng appendix, may presence of pus. Okay? And then in this stage, there will be the damage of the lining epithelium and the entrance of bacteria to the wall. Kaya i-attack din siya ng leukocytes. That's why there's presence of pus. For the third stage, there will be gangrenous kasi obstructed siya, sabi ko kanina, di ba? There's an impairment of blood supply. Walang supply ng dugo. Kakaroon ng ischemia or infarction, ischemia, then gangrene. There will be ellipsoidal infarct of the antimesenteric border near the tip. That is the gangrenous stage. And the last stage, perforation. In this stage, mabibitak na siya kasi sobrang taas ng pressure, hindi na kaya ng appendix. So, stage 1 and 2, congestion and suppurative, is considered as uncomplicated case of appendix. But stage 3 and 4, the perforation and perforated and gangrenous appendicitis is considered complicated. There will be higher rate of mortality for stage 3 and 4. For the pathogens, it can be anaerobes or aerobes, but always remember just the two. E. coli, Escherichia coli, and Bacteroides fragilis. Those are the most common. For the clinical manifestations, first manifestation is of course abdominal pain. So there will be a right lower quadrant pain, flank or back pain. Sa likod siya if the appendix is located retrocecal or behind the cecum. Suprapubic, kung sa pelvic located or nakaposition yung appendix. Testicular pain, pag retroileal, behind the ileum, kasi it irritates the spermatic cord or spermatic artery and the ureter. So nagradiate siya sa my testicles. Then left lower quadrant pain, if the patient has Cytos Inversus. What do I mean with Cytos Inversus? It's a congenital defect that is inherited through autosomal recessive rate, wherein there's the transposition of thoracic and abdominal contents. The organs were supposed to be on the left, were in the right, and vice versa. So in this case, the appendix will be in the left lower quadrant. Very rare, but there are people who have that, like Enrique Iglesias, Donny Osmond, and Charlotte O'Hara. This one. So they said Enrique Iglesias have it. Your hero have it. Also, if there is a malrotation of the midgut or the malrotation of the intestine, during the development of the embryo, there will be an incomplete rotation of the intestine going to the left or to the right. So the appendix will be left hanging on the right upper quadrant. Therefore, the pain of the patient suffering from appendicitis with a malrotation of midgut will be on the right upper quadrant area. Another clinical manifestation is nearly always present. 95%, mawalan siya ng ganang kumain. And then there will be vomiting, pagsusuka, 75%, obstipation, and diarrhea. Obstipation is different from constipation, okay? So constipation is the infrequent or difficulty of passing stools, wherein obstipation is one step further than constipation. In obstipation, the person is not able to pass dry, hard faces at all. So the usual sequence, 95% of people having appendicitis, they have anorexia, then abdominal pain, then vomiting. So mawawalan muna sila ng ganang kumain. Then magkakaroon ng sakit sa right lower quadrant area or kung pwede rin sa ibang part. And then there will be vomiting. So this is the most common sequence. And just memorize APV. Alphabetical siya. Anorexia, abdominal pain, and vomiting. Okay? Next. For the signs, we have direct and rebound tenderness at McBurney's point. So direct tenderness, when you will palpate at the right lower quadrant area, the patient will feel the pain. While rebound tenderness at McBurney's point, the patient will feel the pain after you leave your hand after palpating the right lower quadrant area. We have also SOA sign, obturator sign, Markel sign, or heel drop jarring test, involuntary muscle guarding, and Rovsing sign. Now I will show you what is SOA sign.
Okay, so now I'm going to lift your leg up. Just relax and let me lift it for you. And
Yes.
point to if you have any pain anywhere. The second way to elicit the psoas sign is to get the patient to roll onto their left-hand side and then to extend the leg at the right hip. Do you mind rolling onto your left-hand side for me? And keep your leg straight. And I'm now going to move the leg back. Just let me know if you feel any pain.
Okay, so you have seen how can you elicit the SOA sign. Next is the obturator sign.
To test for a positive obturator sign, what you'll be doing is you're going to be flexing the knee and flexing the hip to both 90 degrees. Next, you're going to internally rotate the thigh by bringing the ankle lateral, and the knee should stay about midline, possibly a little interior towards midline. What this is doing is you're going to be internally rotating the thigh, placing stress on the obturator muscles. Your appendix lies on top of the obturator muscles, and as you place stress on those muscles, it's going to irritate that appendix and cause pain. So a positive obturator test is going to be pain. Okay.
So this is when you elicit the SOA sign. You will hyperextend the leg backward. Let the patient lie on his left side. Then right thigh is extended backward. And then when the patient will feel right lower quadrant pain, that is positive psoas sign. It means you have irritated the iliopsoas muscle. It means also that the appendix is located retrocecal. In obturator sign, the patient will lie supine while he will lie on his back, as you have seen in the video, and then you will flex the knees and the hips 90 degrees, then you will internally rotate the legs. And then the patient will feel pain because the inflamed appendix will irritate the obturator internus muscle. Now, this is Robson sign. You will palpate on the left side, and the pain is elicited in the right lower quadrant area, which is suggestive of acute appendicitis.
A positive Robson sign is found in acute appendicitis. It is a variation on rebound tenderness. To perform this test, press slowly and gently into the left lower quadrant of the abdomen, then quickly release your hand. Sudden pain in the right lower quadrant is a positive Robson sign. Okay, Tom, I'm going to palpate the left lower quadrant down here with quick release and let me know where you feel the pain.
Okay. So you have seen the different signs. Sa Merkel signs naman, you will just ask the patient to tiptoe, stand on his toe, tapos biglang ibabagsak yung tayo niya. Mararamdaman niya yung pain as the heel will thump the floor on the floor. Mararamdaman niya yung pain sa right lower quadrant area. So we have this Alvarado scale or Alvarado scoring system. Is the mostly wide scoring system that is used in appendicitis. So for the symptoms, just remember Mantrel, migration of pain, anorexia, nausea, vomiting, tenderness. But remember that right lower quadrant tenderness is 2 and rebound tenderness is just 1. Elevated temperature, leukocytosis. Leukocytosis means increased number of WBC. And then left shift leukocytosis or neutrophilia. Mataas ang neutrophils. So, just remember Mantrel. Migration of pain, or 90% of patients who are coming to the emergency room will tell you that pain is started from periumbilical area. Sa gitna ng tiyan, nag-start yung sakit, and then magmamigrate siya sa right lower quadrant area. It has something to do about visceral pain and parietal pain. You don't have to dwell on that. So, anorexia, mawalan siya ng ganang kumain. Remember the APV, anorexia, then abdominal pain, then vomiting. Okay? With a score of 10. Now, if it's 9 to 10, almost certain, prepare na yung OR. I-NPO ang patient. Refer mo na rin siya sa ANES para makapag-ready ang ANES, anesthesiologist. 7 to 8, high likelihood of appendicitis. You still need CT scan or ultrasound to at least confirm. 5 to 6, compatible but not diagnostic of appendicitis. So 5 to 6 and below, they are usually treated with antibiotics. Tapos pag umokay sila, discharge sila. So for diagnostics, you will do CBC para malaman mo kung may leukocytosis, kung may neutrophilia, and then urinalysis, may hematuria and pyuria. If there is yung inflammation ng appendix is great enough, then it will irritate the ureter and the urinary bladder, and it will cause hematuria and pyuria. That's what Swartz said. And then WBC, mataas ang white blood cells, leukocytosis. For simple, pag stage 1 and 2 lang, 10,000 to 18,000 per cubic millimeter. Pero pag perforated ang appendix, expect it. It's more than 18,000 per cubic millimeter ang white blood cells. Also, for diagnostics, CT scan and ultrasound, they are most commonly used imaging exam in patients with abdominal pain. So, CT scan is mas favored kasi mataas ang sensitivity and specificity, like 97 to 85, 97%, then 94% ang specificity, tapos sensitivity 97%. But then, it's expensive. Pag hindi naman kaya ng patient, then ultrasound. Tapos pag ang patient is female in reproductive age, it's a must na kailangan magpa-pregnancy test. It doesn't matter kahit walang boyfriend or kiniklaim nila na hindi sila pregnant. It's a protocol ng hospital. Pa-pregnancy test mo kasi it can be possible ng gynae, pathology, at pwede rin buntis yung patient, so hindi siya pwede mapa-CT scan, then ultrasound is the safer one. So, laparoscopy, nagpapasok sila ng scope. It can be diagnostic and therapeutic at the same time. And it's very useful for the female kasi in case na nagpasok sila ng laparoscope tapos nakita nilang hindi naman inflame ang appendix, at least makikita nila ang gynae pathology. Minsan may ovarian torsion, may endometriosis, or tubal torsion, fallopian tube, napilipit. So, yun. It can mimic the signs of appendicitis. If there is an appendiceal rupture, there will be an increased morbidity and mortality. But there is no accurate way to determine the occurrence of rupture. But then the patient will have fever of more than 39 degrees Celsius and then white blood cells of more than 18,000. Then there is localized rebound, involuntary muscle guarding, and signs of generalized peritonitis. What is the sign of generalized peritonitis? Hard broad-like abdomen. Yun yata yung question sa board exam. Hardboard-like abdomen. And then, ill-defined mass, phlegmon. Nice to know lang yan. Matted loops of bowel adherent to the inflamed appendix. For the differential diagnosis, you don't have to memorize this. It's just nice to know. Pero possible kasing ito yung mga sakit na pag hindi man appendicitis yung case ng patient at na-misdiagnose siya, these are the possible cases. So for the treatment, appendectomy is the standard of care, wherein the open is the conventional approach and laparoscopic appendectomy is the trend now. But before the surgery, you will put the patient nothing per orem, huwag mo siyang pakainin ng at least 4 to 6 hours. Kasi the patient will undergo operation and he will be under general anesthesia. Pag gagamitan ng general anesthesia, magre-relax lahat ng nasa loob ng tiyan, including the intestines. Pag kumain ng patient mo in less than 6 hours, let's say kumain siya 30 minutes before the surgery, ginamitan niyo siya ng general anesthesia. Nag-relax ang intestine, lahat ng kinain niya aatras, pupunta sa lungs, mag-a-aspirate, mamamatay siya sa OR table. So it's a must, okay? And then intravenous fluid, adequate hydration, i-correct mo ang electrolyte imbalance bago niyo siya operahan. Preoperative antibiotics para maiwasan ang post-op surgical site infection. Usually, nagbibigay sila ng antibiotic 30 minutes before nila buksan yung sugat. Buksan yung tiyan. Open appendectomy, we have different incisions. The most common is the McBurney's incision, which is oblique. And the other one is the Langer's-line incision or the modified McBurney. It's called Langer's-line incision because it follows the Langer's line of the external oblique muscle of the abdomen. Now, next is the Rocky-Davis transverse incision. Pag masyado pang bata, minsan ginagawa nila, binababaan nila yung Rocky-Davis incision para naman paglaki niya, hindi siya kawawa pag magbibikini, ganon. So, if hindi siya mahanap in Rocky-Davis incision, nag-i-extend medially through Fowler wear extension. And if hindi pa rin makita, nag-i-extend laterally through Rutherford-Morrison extension. Kung obese yung bata or patient, nag-i-extend talaga ng incision. Pero pag perforated ang appendix, midline. Okay? This laparoscopic appendectomy, magpapasok lang sila ng 3 trocar, isa sa umbilicus, isa sa suprapubic area, minsan 2 sa umbilicus. Pero may new trend ngayon na 1-hole laparoscopic appendectomy, pero only few surgeons pa lang ang gumagawa. And then, ito naman, sa laparoscopic appendectomy, it is more expensive, pero the patient can go home in 24 hours. Mabilis ang recovery, mami-minimize ang surgical site infection kasi maliliit lang ang sugat nito, 1 centimeter. And then pag nag-heal na siya, parang wala lang, hindi tulad ng incision ng open appendectomy. The problem is, kung rupture ang appendix, kailangan i-open kasi mag-explore sila kasi kalat-kalat yung nana sa loob. Hindi naman pwedeng mag-iwan ng remnants doon. So, this is an example of laparoscopic appendectomy. Ito lang ang shortest tapos detailed, kaya ito ang ipapakita ko.
Hello, this is a case of laparoscopic appendicectomy. Laparoscopic appendicectomy is slowly becoming the gold standard for the acute appendicitis. This patient has interval appendicectomy. There was previous episodes of appendicitis. This is appendix, and we are using a striker mini alligator to lift the appendix. The advantage of using the alligators are that the patient will have only 2 ports, and it is not coming through the port, it will come percutaneously. Now we will first desiccate the major appendix with the help of the Roby dissector. This is a bipolar Maryland that is also called as Roby dissector, and you can use it with the bipolar plasma kinetic or radio frequency generator. Now this is the seizures after coagulation, which is cutting, intermittent desiccation, and then dissection will be performed to remove the major appendix completely. If you want to prevent the occurrence of the recurrent appendicitis, or if you want to prevent the incomplete appendicectomy, then it is necessary that you have to dissect the major appendix up to the base of the appendix. Sometime lateral and sometime medial traction is required on the appendix, and nicely all the peritoneum should cut, and the major appendix should be skeletonized completely up to the base. Now it is completely clear, and we are using the Mishra's knot here. The loop is created. The configuration of Mishra knot is 1-1-1-1-1. It is 1 hitch, 1 wind, then 1 lock, 1 wind, 1 lock, and again 1 wind, 1 lock. This is very secure knot. Only 1 knot is more than sufficient. And just 5 mm above the knot, you can apply bipolar, and then again it will be desiccated. Monopolar should be avoided because it will burn the tissue where the knot is applied, because if the area is narrow, heat is more at that point. But in bipolar, it will be only in between the jaw, so it will seal the appendix also, and it will burn the mucosa also. The chances of the mucocele of the appendix is not there, and then it is cut. Then we are using 5 mm telescope now, so that appendix will be taken through the umbilical port. So thank you very much for watching this video. This was just a simple case of laparoscopic appendix.
So, in laparoscopic appendectomy, magpapasok lang sila ng trocar, tapos laparoscope, yung may camera na tube, and then tatanggalin yung appendix, and then according to the video, para maiwasan ang recurrence ng appendicitis, you should make sure na hanggang sa base, hanggang sa may cecum. Now, in locating the appendix in OR, follow mo lang yung tinea coli, yung line sa may large intestine, then the confluence, doon na yung dulo niya. Kasi madaling sabihin, ileocecal junction, yung sa may junction ng big intestine, tapos yung sa may cecum. Pero pag andun ka na, halos pare-pareho na yung kulay ng intestine. So you just have to trace the Taenia coli of the large intestine, tapos sa dulo nun nandun yung appendix. For the prognosis, very low. Kung may early operation, early diagnosis, early operation, then death from appendicitis is very low. There's only 0.2% to 9.9% unless if nag-rupture ang appendix prior to surgery. Then, pag simple rupture lang, di 0.06. Pero pag ruptured siya na talagang wasak, pati cecum, 3% or 3 out of 100 people are dying. So, hindi siya dapat dinidelay. And then, death can be due to uncontrolled sepsis, peritonitis, intra-abdominal abscess, or gram-negative septicemia. Kasi yung infection kakalat sa dugo. Then, can be cardiac, pulmonary insufficiency for the elderly. Also, pulmonary embolism, pero very, very rare. Then, aspiration. Okay, thank you and God bless all of you. I hope nag-enjoy kayo.
All right, ayan. Thank you so much, Doc Flory, for that very comprehensive lecture on appendicitis. I'm sure maraming natutunan yung ating mga students today sa inyong lecture about appendicitis. For now, we shall be entertaining questions coming from students.
Okay po.
Okay lang sa'yo.
Sige, sir.
Ayan, baka may mga tanong sila. Ayan. Siyempre, hindi na nila tatanungin kung single pa si Doc kasi nakita na nila si...
Sorry, laptop niya kasi to. Kaya hindi ko alam kanina sa ko hanapin yung mga...
Ayun. Okay. So, anyone from the group kung may gustong magtanong kay Doc about appendicitis?
Sir, may tanong po ako, sir.
Okay. Sino yan? Si Kathleen?
Yes, sir.
Ayun, Kathleen. Sige, go.
Is there a risk that a pregnant woman will have appendicitis po?
Yes. Nag-opera na rin kami ng mga pregnant woman with appendicitis. Pero not on third trimester. Usually, ang risk is first trimester and second trimester. So, pag may pregnant woman, dapat increase ang fiber diet, tapos increase fluid intake para hindi siya magkaroon ng fecal lift. Okay?
Okay po, thank you.
Alright. Thank you so much, Kathleen. Kathleen, doktora si Kathleen ay incoming first year. Ayan, first year siya ngayong August.
Kaya mo yan. Mabilis lang ang panahon.
Thank you.
Oo nga, parang kailan na nung nag-nursing ka sa...
Oo, sir.
Ngayon, doktora na. Alright. Any other question? Sino pang may tanong? 4th years. Ayan, sino yung mga 4th years natin dito? 3rd years, 2nd year, and 1st year. Nako, bakit wala silang tanong? Sige na, 2 more questions siguro bago natin ibigay yung tawag dito, time ni doktora. By the way, Happy Independence Day sa ating lahat.
Happy Independence Day.
Ayan,
Sa mga single.
Sa mga iniwan ng jowa, ayan. Independence Day.
Sa mga pinaasa.
Parang may hugot ka, doktora.
Mga nag-ghost. Joke lang, sir.
Alright. Sige na.
Sir, magtatanong pa po ako one more.
Okay. Ayan. Kathleen, go.
What foods make appendicitis first po?
What foods may cause appendicitis? Ayan.
So, yung mga mabubuto kasi pag may appendicitis ka na kasi hindi ka na talaga kakain, mawalan ka na ng gana. Parang sa acid reflux din or gastritis, pag maanghang kasi madaling mag-irritate ng mga intestinal mucosa. Maanghang, iwasan mo, mabubuto, gano'n. Yun lang naman. Kasi yung mga may seeds, yun yung main cause. So, iwasan siya. Pero pag mag-aggravate ang hinahanap mo, I think yung mga spicy foods lang. Kasi mag-irritate sila ng intestinal mucosa. Then more production ng acid, tapos inflame ng ang appendix mo, then magkakaroon ka lalo ng pain.
Ay, okay po. Thank you.
Welcome.
Alright, sige. One last question sa ating mga first year, second year, dali, labas na.
Gio, sir.
Gio, Kuya G, good afternoon. Sige na. Ang ating future doctor. Actually, for your information, si Dr. Flory ang pang-apat na nursing student natin. Na nurse natin from PLT na naging full-fledged doctor. Ayan. Si Kuya G ang pang-lima na.
Sir, Doc, ito ang tanong ko. Is surgery is the only method used to treat appendicitis? So, kung meron po, what is the non-surgical treatment po?
Stage 1 and 2, it can be treated by antibiotic. Pero pag ikaw kasi yung may appendicitis, since other journals said after 7 years old and some other journals said after 20 years old, useless na ang appendix, bakit di mo na lang ipatanggal? Diba? Tapos magkakaroon ka pa ng occurrence ng appendicitis. So, mas safe kung ipatanggal mo na lang. So, ako nga kung magkakaroon ako ng other surgery, mas gusto kong ipatanggal na lang. Pero yun, can be treated with antibiotic. Pag umokay siya, then good. Discharge siya from hospital. Pero pag hindi at tuloy-tuloy ang pain, mag-commit ka sa surgery. Kasi magpe-perforate siya.
Alright. Thank you, Kuya G. Any more, Kuya G? Baka may follow-up question ka.
Sir, wala na.
Okay. So, sige. Kung wala nang katanungan. Thank you so much, Dr. Flory.
Thank you, sir.
Okay. Sa mga susunod na webinar lectures natin. And we hope to see you sa PLT College very soon.
Thank you, sir.
Ma-invite ka namin in our future endeavors later. Future endeavors in PLT College of Nursing.
Salamat, sir. God bless all of you. Stay safe.
Bye-bye. Thank you so much. God bless.